Today we are going to talk about the minimally invasive techniques that are available for treatment of infertility in rural areas. Infertility is not an uncommon condition. 1 out of 7 couples who are married are infertile. Before the era of diagnostic laparoscopies, evaluation of infertility was very difficult because X-rays like hysterosalpingogram was very inaccurate, and it was not acceptable to many patients to have a big laparotomy for evaluation. Without diagnostic laparoscopy, it is difficult to diagnose conditions like pelvic inflammatory disease, adhesions, endometriosis, etc. with certainty. Again, conditions like Asherman syndrome were very difficult to diagnose without the minimally invasive techniques. Today we will show you the various minimally invasive techniques that are possible in rural areas. This is the ureterorhinoscope that is used generally in urology. We can use this to have a look at the fallopian tubal orifice. We place the patient in lithotomy position and dilate the cervix. Then we use the scope to visualize the opening of the fallopian tube. And what we can do is, with methylene blue, we can use the pathfinder to flush any adhesions or any blocks which are there in the fallopian tube. This has been very successful. If that doesn't work, then what we do is we use a 0.025 inch guide wire and try and open out any of the blocks which are there in the fallopian tube. These are again instruments which are normally available with any urologist. We can use the resectoscope to resect the septum in the Asherman syndrome, or small fibroids which may be present inside the uterus, which is a cause of infertility. If it is difficult to pass a resectoscope, even the ordinary cystoscope along with the Bugbee electrode could be used for vaporizing or cauterizing these small defects. This is part of the lift apparatus that we use for diagnostic laparoscopies. The advantage is that each place has a different type of operating table, and it's difficult to use the standardized lifts. So what we have done is to make an arrangement where the size could be altered so that it can fit into any of the operating table. We also have a special V-shaped groove which makes it hold on to the table very tightly. The most important procedure that we do is the diagnostic laparoscopy for infertility. We go through a small incision in the umbilicus. We lift the umbilicus with the 2 tall clips like this and make an incision starting from the middle of the umbilicus. We use these special S-shaped retractors to retract and make a small incision just below the umbilicus on the rectus, just enough to allow an index finger. So what we do is we put an index finger and sweep all around the umbilicus to make sure that there are no adhesions and there are no bowel or intestine between the abdominal wall and the apparatus. Then what we do is use this special apparatus which we have designed to pass into the incision like this and lift the anterior abdominal wall. Once again we pass the finger to make sure there is no intestine between the abdominal wall and the device. We can also confirm it by using the telescope. So once this is done, the abdominal wall is lifted and held in position. Once abdominal wall is lifted, this is the portion that is used for keeping it in position. It has a ball and socket joint which allows a lot of movement, and also there are just 2 levers which can be used to keep the lift in whichever position which that is desirable. And locking is very simple, just the use of these 2 levers, and the abdominal wall can be further lifted if necessary. Once in position, the patient is placed in steep lithotomy position so that the intestines move away from the area of interest. This is developed as a wound protector. We can use this as an umbilical port. We can just pass it inside and this would keep it open. And there is no soiling of the instruments with the blood when we pass the instruments. During the surgery, these are the common instruments that we use. This is a atraumatic grasper. We use to move the intestines away from the area of interest. Sometimes it's useful to put a uterine manipulator so that the uterus also could be moved in whichever direction is necessary. This is a hook which can be used for releasing adhesions. And if necessary, we can use either the vessel sealing equipment or the harmony equipment to release adhesions which are fairly common and contribute to infertility. However, the most common instrument that we use is the puncture needle we use for puncturing the ovary in polycystic ovarian disease. We use a grasper like this, which obviously cannot be used during conventional laparoscopic surgery, to hold the ovaries up, and then we make multiple punctures. In Mizoram, during the last 1 year, we found that almost 40 to 45% of the patients on whom we had operated had conceived during the last year. When we are doing procedures, especially single incision surgeries, vessel sealing equipment like this is very handy. We can remove the ovarian cyst or half the ovaries or whatever is necessary without causing damage to the other tissues using the vessel sealing. Although these are made by Valley Lab, it is possible to connect them to many of the locally produced generators like the Allen's generator that we have. We have been doing these procedures for the last 2 decades. We started them in a very remote hospital in Assam, and we found that almost 18% of the patients whom we treated conceived. Then we started working with gynecologists who are specializing in infertility work, and this improvement from 18% went up to almost 30 to 40%, because it should be combined along with medical treatment and these surgical procedures. And these are very patient friendly because the scars are very small. Once a umbilical scar heals, it's hardly visible and it's very difficult for people to make out that they even had a surgery. So the patient acceptance is very good. And because unlike the regular traditional laparoscopic surgeries where single incision require a much bigger incision, the size of the incision that is necessary is only 1 or 2 centimeters, and which shrinks further with the healing. So we have not had much problem with the wound infection. The infection rate has been less than 6% in many of the studies. And again, working in rural areas, generally the infection rate is much less. Hence, this is a very useful procedure. And big advantage is that it is possible to do them under spinal anesthesia. Few of the things which needs to be remembered is that because we are giving spinal, it takes a little time for the medicine to get fixed. So you need to wait for about 15 to 20 minutes after giving the spinal anesthesia to have a steep lithotomy position. And then again, because we are using a single incision, it is important to do whatever we do under vision so that there is no damage to the intestine or omentum or any other structures without our knowledge. And before closing, it is good to inspect the entire abdominal cavity look for injuries or any other pathologies which might be there. And recently what we have been doing is we are comparing leaving the methylene blue or saline solution that we use for chromotubation, because we found that gives less post-operative adhesions and the chance of conceiving is more. In conclusion, it's a very simple procedure which anybody can do, and it's possible even in very remote areas because it's carried it under spinal anesthesia, and the sturdy equipment make it less expensive, and the use of traditional open instruments make it easy to learn.